Welcome to this explainer. When we look at clinical care, it isn't just about administering medications or checking boxes off a list. It's really about acting like a medical detective. It's about recognizing the incredibly subtle and sometimes not so subtle physiological cues our bodies are constantly giving off. Decoding these signals in real time can literally be the difference between saving a life and a totally tragic outcome. Today, we're going to look closely at two major systems, the respiratory and the gastrointestinal systems, and learn how to read the vital clues they're giving us. Let's dive in.
Here is our roadmap for today. We'll start with evaluating respiratory mechanics, then see some respiratory crises in action. From there, we'll move down the body to explain inflammatory bowel disease, tackle the acid reflux puzzle, and finally, managing bowel elimination. Section 1. Evaluating respiratory mechanics. Let's begin by looking at the baseline mechanics of how our bodies draw in oxygen. You absolutely have to understand the normal to recognize the abnormal. It's kind of wild to think about, but breathing, it's an entirely passive, involuntary activity. We don't have to force air into our lungs. Air flows in simply because the pressure inside our chest drops below the atmospheric pressure outside. It then flows back out thanks to the natural elastic recoil of our lung tissue. What keeps our lungs partially expanded all the time is this delicate negative pressure maintained between the pleural membranes. Now, if that balance gets disrupted, say by a puncture wound or a buildup of fluid, the whole system is immediately compromised, and suddenly breathing requires an immense conscious effort. So when a patient's breathing goes south, we look at their arterial blood gases. But let's be real, staring at raw numbers during a chaotic emergency can be super overwhelming. That's where the ABG tic-tac-toe method comes in. It's a clever visual trick nurses use to rapidly decipher the data. By plotting the pH, carbon dioxide, and bicarbonate under acidic, normal, or basic columns, you create a quick little lineup. If the markers line up vertically on the acidic side, boom, you instantly know you're dealing with acidosis. It essentially transforms a complex metabolic puzzle into an instant visual diagnostic tool, which saves precious seconds when your patient is crashing. Moving right along to Section 2, Respiratory Crises in Action. Let's put these diagnostic tools to the test and step right into the high-stakes world of a hospital, post-anesthesia care unit, or PACU. Take our first patient case here, Ken. Ken is an 81-year-old gentleman who came into the ER after a fall, which led to a highly successful left hip surgery under general anesthesia. Everything seemed totally fine, but here is where your detective work kicks in. When he arrived in the PACU, he was completely unresponsive. His skin had taken on this terrifying reddish-blue hue, his breathing was dangerously slow and shallow, and his oxygen saturation plummeted to a staggering 56% on room air. Even with rapid oxygenation attempts, we couldn't get him above 60%. His baseline had completely fallen off a cliff, from a stable post-op patient to someone on the absolute brink of respiratory collapse. And things escalated fast. Ken went into pulseless electrical activity, or PEA. Now, this is a terrifying rhythm because the heart's electrical system is still firing on the monitor, tricking you into thinking there's a heartbeat, but there is absolutely zero mechanical pulse. No blood is pumping. This required immediate, aggressive intervention. A code blue was called, CPR was initiated for 2 minutes, and epinephrine was administered. Once Ken was finally stable enough to transport, a CT scan revealed the true culprit hiding behind this massive respiratory failure. It was a subsegmental pulmonary embolism that had traveled and lodged deep in his lungs, causing massive right-sided heart failure. Now, flip that script. Meet our 20-year-old patient Marcus, who presents a completely different kind of respiratory crisis. He arrives at triage in an absolute panic, saying, "I can't get my breath." He's got loud, audible wheezing, he's breathing a rapid 32 breaths per minute, and he can only speak in short, gasping sentences. His oxygen saturation is sitting at a really concerning 88%. While Ken's crisis was silent and unresponsive, Marcus's crisis is incredibly loud, physically exhausting, and obvious. This is a severe asthma exacerbation. His bronchi are violently inflamed and packed with mucus, completely blocking that airflow. He needs immediate supplemental oxygen and fast-acting bronchodilators to force those airways back open before his respiratory muscles just completely give out. Okay, Section 3, Inflammatory Bowel Disease explained. We're shifting gears and heading down the body to unravel the GI system. Because just like the lungs, the GI tract gives off very specific warning signs when things go wrong. People mix up the two main types of inflammatory bowel disease
all the time, but ulcerative colitis and Crohn's disease actually behave in completely distinct ways clinically. Ulcerative colitis typically starts down in the rectum and spreads upward in this continuous, unbroken pattern. But importantly, it only affects that inner mucosal layer. Because of how it inflames, dangerous complications like toxic megacolon are much more common. Crohn's disease, on the other hand, involves the entire thickness of the bowel wall. That's called transmural inflammation. And instead of a continuous spread, it presents as healthy tissue mixed with damaged areas, which we call skip lesions. Plus, these can randomly pop up anywhere along the entire GI tract from the mouth to the anus, making it like our random patchwork that's uniquely challenging to treat. Let's pause and play medical detective again with patient A.B. She's 32, has a known history of ulcerative colitis, but today, she tells us, it has never been this bad. She's having severe diarrhea, which sure is expected, but check out these crucial new clues. She's lying perfectly still on the exam table, she's got a brand new 101-degree fever, her breathing is noticeably shallow, and she has intense rebound tenderness in her left upper quadrant, meaning when you lightly press on her abdomen and let go, the pain suddenly spikes. Take a second. What on earth is happening here? The answer? A. AB is showing the classic, terrifying warning signs of peritonitis. Because ulcerative colitis causes such severe ongoing inflammation, the weakened bowel wall can actually perforate. When that happens, toxic intestinal contents spill directly into the sterile abdominal cavity. Yikes. That rigid abdomen, the sudden fever, and especially her reluctance to take a deep breath because moving the diaphragm physically scrapes against those inflamed organs, these are massive flashing red flags. As a clinician, catching these subtle shifts in her pain and breathing is absolutely critical to getting her into emergency surgery before systemic sepsis takes over. Section 4, the acid reflux puzzle. Let's transition from those acute, life-threatening emergencies to chronic conditions that can just severely ruin a patient's quality of life over the long term.
Think about CS, a 49-year-old guy who keeps waking up in the middle of the night with this deep, burning pain in his sternal area. He's been downing over-the-counter antacids, which help for a bit, but recently this occasional heartburn has morphed into a daily, exhausting occurrence that's actively ruining his sleep. So when exactly does that standard, I ate too much spicy food, heartburn, cross the line into a pathological condition that needs real medical intervention? Well, CS's symptoms, the frequency, waking up at night, and the specific location of the pain point straight to GERD, or gastroesophageal reflux disease. It's no longer just a nuisance, it's a chronic disease process that is actively damaging his esophageal lining. Managing this requires a strict 1-2 punch. Yes, we use targeted prescriptions like omeprazole, a proton pump inhibitor that literally shuts down stomach acid production at the source, but equally crucial are the serious lifestyle modifications. We're talking significant weight management, changing his daily eating schedule so he's not hitting the pillow right after dinner, and ruthlessly cutting out those trigger foods.
And finally, Section 5, Managing Bowel Elimination. Let's explore the highly actionable strategies nurses use to manage the complex, day-to-day realities of constipation and diarrhea. Look, conquering constipation is not just about handing out a laxative. In fact, overusing laxatives is dangerous because it causes bowel dependence. It really requires a systemic fix. You need 20 to 30 grams of dietary fiber to add the necessary bulk, and you need a solid 2 liters of fluid to soften that bulk so it can actually move. And here's a crazy fact. Caffeine is actually counterproductive here. People love their morning coffee to get things going, but caffeine is a diuretic, pulling much-needed fluid right out of the body and away from the bowel. Also, delaying the urge to go makes everything exponentially worse. The longer stool sits there, the more water the colon absorbs from it, making it harder, drier, and just incredibly difficult to pass. Now, managing diarrhea requires the exact opposite game plan. With diarrhea, the body is expelling fluids and contents way too rapidly. So, our primary clinical concern intensely shifts to aggressive fluid replacement and locking in that electrolyte balance to prevent the patient from slipping into hypovolemic shock. We also have to be hypervigilant about skin integrity, constantly applying moisturizing barrier creams to prevent painful breakdown from the acidic stool. And of course, we've got to ensure rigorous isolation precautions are in place just in case the diarrhea is highly infectious, like a C. diff infection. Wow, we've covered a ton of ground today, haven't we? From the silent drop in oxygen in a post-op patient to the rigid abdomen signaling a perforated bowel. I want to leave you with a final thought. The next time a patient's baseline subtly shifts, whether it's just a tiny change in their breathing rate or a brand new location for their pain, will you have the detective skills ready to decode those signals, piece together the puzzle, and ultimately save their life. Keep looking for the clues, keep connecting those dots, and never stop learning. Thanks for joining me on this explainer.